Please welcome Jorge Calzada, Ben Shorbert, Dr. Von Nguyen, and Brittany Bogle for our next panel for Artificial Intelligence, Technology, and the Role of Healthcare Data.
Hello, welcome everybody. I'm Jorge Calzada. I'm the Platforms Division Director within the CDC, and I am brand new to public health. I have a background in artificial intelligence and machine learning, where I spent the last 20 years or so helping organizations build this capability, and I'm so excited to bring this capability into the public health sector. And I am amazed by the panelists that we've gathered here today to talk about artificial intelligence and the role of technology and healthcare data in healthcare. So with that, I'd like to introduce my, my fellow panelists. Vaughn?
Hi, everybody. I'm Vaughn. Wow, that was quite loud. So I'm Von Nguyen. I'm an internal medicine and primary care doctor by training. And so I work now at Google, which has just been a fascinating time. So I'm based on the clinical team, and I work within the health artificial intelligence research branch. And so it's just been an incredibly fascinating time, and just really looking forward to this conversation.
Am I up? Hi, everybody. My name is Brittany Bogle. I'm a principal data scientist at IBM. I also wear another hat. I'm on our global industries team focused on our strategic healthcare clients across the United States and the world. And my role is really to focus on figuring out what use cases are top of mind, spanning both our data science and an AI portfolio, but our other technologies as well.
Ben?
Ben Schobert, having a realization that that's a pre-pandemic picture, so that is me. I'm the Chief Alliance Officer at Microsoft Healthcare and Life Sciences. We, for the better part of a decade, have run an incubation organization in Microsoft Research, organized around a variety of healthcare and life science specific artificial intelligence incubations. My team graduated from that AI research organization. We're now on the commercial product side. My team embeds with a handful of very strategic healthcare payer, provider, pharmaceutical customers. We spend 5+ years with those customers getting really deep in their digital transformation. And as you could imagine, right now are very heavily indexed on helping them think through what their AI strategy should be.
Thank you. Every conference that I've been in 2023 has, the elephant in the room has been generative AI. We are not going to be the exception. We definitely see this excitement in industries embracing generative AI. And I'm wondering, what are some of the best use cases that you've seen of generative AI in healthcare? And if we could start with Vaughn.
Yeah, toward your point, Jorge, I was living on a panel last week at AHIP, and we talked about the same thing. And the beauty of it is that I was actually on a panel with some providers as well as payers, and we were talking to this. The use case we're hearing a lot of from a provider perspective is, how do I make my work more efficient? So I remember being a provider. I'd see my patients during the day, 15 to 20-minute visits, and then I'd spend 2 hours every afternoon writing and documenting the note. It just drove me crazy because that was less time I could spend with my family or a patient I couldn't see during the day. So the use of generative AI to sort of summarize that information, put in a note, is really incredible, just to really allow me to do the things I really love doing, which is seeing patients and not documenting notes or coding to make sure I maximize risk adjustment factors or whatnot. So for those in healthcare, you know that well, I suspect. Another really incredible use case that we were hearing from some of the payers is that, how many of you have actually had to sort of figure out if something was covered? Like for myself, it was understanding sort of coverage for neuropsychological testing. But how many of you have tried to go to a health insurance company and tried to figure out what was covered? How many of you got it done within an hour versus versus the 2 days calling different people? I would argue that I'm pretty expert in healthcare. I was actually the chief medical officer of the Blue Cross plan in North Carolina as well prior to joining Google, and I couldn't figure it out. But these new tools are able to pick out these needles in a haystack, help sort of a consumer, a patient, trying to figure out what's covered, buried in that benefits booklet, understanding what the copay might be, understanding the cost share, and putting that information in an understandable way at the appropriate reading level, and frequently in the right language so a consumer can understand. So some real exciting opportunities to take complex information, bring it together, and make it available to sort of normal people.
Yeah, I fully agree with everything you're saying, Vaughn. What we're seeing is a lot of our healthcare providers and payer clients that we're talking to are very interested, obviously, in the potential for advanced technology like generative AI to help them in areas like genomics and advanced drug discovery, but that's kind of put to the side for now because the use cases that they're most interested in are areas that help them with operational improvement, like you were saying, workforce efficiency, helping those caregivers get back to top of license activity and reduce redundant efforts. And yeah, the use cases you gave were similar to what I had in mind around prior authorization, using retrieval augmented generation kind of capabilities to pull out information specific to a payer's plan or an explanation of benefits and being able to map that to a medical necessity requirement. And then on the other side of that, claims processing, and then responding to claims and appealing denials, for example.
For those of you who served in the military, I think the answer to your question would be referred to as a target-rich environment. So I agree with everything that was said, and in our team, one of the first initiatives and incubations that we took to market was something called Empower MD that ultimately led to us acquiring Nuance. And that was a healthcare-tuned, natural language understanding, natural language processing capability that actually, as its output, created a structured SOAP note. And this is 5-7 years ago. That was very successful. So just to your point, I think the idea of AI, the use case around AI to rehumanize the patient-physician interaction, whether that's in person or that's virtual, where as a physician, as a practitioner, you really are paying attention to the human being. You're picking up on body language. You're picking up on hesitancies in their answers to your questions. I think that's a profoundly important use case. I think what we do with that use case is an open question, right? Do we give physicians and nurses some time back, or do we burden them more with that extra time that the technology gives them? So I think in the provider space, this idea of ambient clinical intelligence is, to me, extremely rich, very, very exciting. I think on the payer side, just to double down on something Brittany said, I think there's a lot of things like prior authorization, a lot of very paperwork-intensive, fingers on keyboard intensive processes where there are efficiency gains, and I think done properly, that leads to savings in the system. And I think it also helps people feel like they're actually getting an explanation of benefits that they can understand. And then on the pharma space, Brittany said it, I think we're on the cusp of what these large language models are going to do in the field of precision medicine, computational biology, and drug discovery. And for everybody that was freaked out by how quickly these mRNA vaccines came to market, I think we're going to see this next generation of novel therapeutics really surprise us all. As is always the case with new technology, we have to figure out how to pay for it, but that's a different conference.
Thank you. So Microsoft, Google, IBM, you guys aren't in healthcare, right? You guys serve a lot of different industries. What are some of those really amazing use cases that you've seen in other industries that you would love to see ported to healthcare? And maybe we could start with Ben.
I mean, on a wish list, a national patient identifier. I mean, it's something so basic. We talk about the data estate that's going to be necessary for healthcare systems to reason over and to light up these various use cases. I mean, something as predicate as that would be close to the top of my wish list that financial services and other regulated industries have.
I would throw out there workforce management. It's an area that every conference and seminar I go to around healthcare providers is top of mind. 6 years ago, while that was obviously a challenge, whenever I joined IBM, it was not the top use case. But now, when we think about what's translating from industry, I mean, we think about airlines, right? Airlines use IBM and some other vendors' technology to really optimize and predict what is in the healthcare setting patient census levels, right? And the expected forecast and the expected work demand. And being able to optimize against that and be reactive and prescriptive in how you're actually making your scheduling decisions, as well as how you're making even your hiring and retention and understanding what attrition might be, down to the individual level in a trustworthy AI is a use case that I'm having a lot of conversations with providers about these days.
Yeah, so one of the use cases that I'm most interested in is this idea of computer vision. So you can take a satellite image of lots of different things, and then you can begin to understand, do damage assessments of sort of before and after the hurricane blows through, and you can actually do this quite easily with auto-labeling techniques. And many of us have it. We have it at Google. I'm sure you guys have it at Microsoft and IBM as well. It's really interesting. One of the things we say in healthcare is that the zip code is as important as the genetic code. And really being able to use some of these geographic tools to understand health in a very different way, to understand those social determinants, and understand sort of how the neighborhood factors sort of fit into health. So that's one of the places where I think we're going to see real revolutions in the future, and it'll be quite interesting when we get there.
Yeah, at the CDC, we've been big adopters of computer vision. We've built models that look at satellite images to spot cooling towers, because they could be potential sources for a Legionella outbreak. And we have our colleagues over in environmental health are looking through Google Maps and quantifying the amount of sidewalks to quantify how well a built environment is conducive to walking. So yeah, totally agree with what you said. And then just one more question on generative AI. There are so many amazing tools out there, both consumer grade and enterprise grade. How do you ensure that you're using the right tool for the job? When should you sort of use an off-the-shelf model? When should you think about training your own large language model?
Who'd like to start?
Do you want me to start?
Yeah, that's a Brittany question.
Why not? I guess we've all started now at this point. Yeah, I guess as the data science practitioner on the panel, I should probably go first. How you can think about this, how I think about it anyway, and I think my understanding is evolving and how I'm kind of talking to clients about this, is very few healthcare systems or any enterprise, honestly, is going to really have the type of compute available to them, the money available to them, and the skills available to them to be able to build a foundation model from scratch. Frankly, if you go look at the methodologies that's been in the literature in computer science and my field of operations research for decades, we've known that base models or foundation models are possible. And just like everything else in the AI field, it's been enabled and realized through the evolution of technology, where we now have companies like IBM, Microsoft, and Google have those capabilities in place to be able to look at. So what I'd strongly recommend as I'm thinking through with clients how they should approach this is narrow down what your use case is. And by use case for generative AI, what I mean is, what do you want the model to give you? Do you want it to answer a question? Do you want it to provide tone and sentiment from a call center log? Or do you want it to summarize a big document in plain language? That's what I mean by use case. And then look at the repository of models available to you. And basically, that's how you can kind of do some initial prompt engineering to see if it's responsive in a good way, enough for you to be able to fine tune it. The other thing I'll mention is a few things really quick. I ask people as they're thinking about this to think about cost. How much a big, large language model may not be the best model for your really nuanced use case. And larger the model, the more parameters, the more expensive. Where do you want it hosted? So is it safe for you to ping sensitive information to a location hosted in a different environment? And then finally, areas of what data was the model trained on? And if you don't know that, does the owner of that model have the ability to provide you model indemnification? Those are the things that come to mind whenever I think about it.
Such a data scientist answer. And also totally true, yeah.
Have to be my strength.
But I do think there's something really important implicit in what you're saying, which is that the answer to that question goes back to your data strategy, like the data fidelity. Do you have a data model that you've aligned on inside your enterprise? Are you comfortable that you've broken down silos between various parts of the organization? There's some predicate best practices that are necessary to answer constructively, that are part of getting to the answer of question of what is the right approach here? Do I build my own? which is a heavy lift? Or do I take a dependency on something that's available or even something that's open sourced?
Yeah, and the only thing I would say add to this is really anchoring on a comment that Brittany made which is, what's your question? Like I as a business owner and before, I've made this mistake. I've gotten very excited about the new technology, and sometimes that's not a great thing. So you can actually burn through a lot of resources if you're not careful, both in terms of time on your teams, as well as sort of the financial resources. Really nail that question. What's the problem you're trying to solve? And then quite frankly, you can probably call any one of us and we'll help you with the rest. But nail that question because only you can answer that question.
I'm going to switch gears here and talk about responsible AI. I know we heard some of our colleagues in one of the other sessions talk about health equity. So how do we ensure, if we're going to turn over a lot of these tasks to machine learning, to artificial intelligence, how do we ensure that the proper guardrails are in place within healthcare to make sure that we're using AI responsibly? Vaughn, if I can.
Yeah, so when I think about sort of responsible, I actually think of this in two pieces. There's first the bold piece and then a responsible piece. Like we are in this new generation where there are some incredible tools in front of us, like building on sort of typical AI or good old-fashioned AI and moving to sort of these new tools with these generative AI. So there is an opportunity for us to really solve some big problems together and to work collaboratively in that. On the responsible side, I think it's quite interesting. It's a process by which you have to think of it as not one solution, but sort of thinking about sort of equity and sort of how we ensure fairness throughout the continuum. And what this means is at the beginning, when you begin training your data sets and thinking about those, making sure that those data sets are unbiased in a way and checking for those biases. As you're beginning to evaluate the outcomes, it's really easy to sort of pick a couple of people who work at your company to evaluate an AI model, but systematically going across and making sure that the individuals who are evaluating the AI come from different communities, different socioeconomic statuses, different countries even, to make sure that you have true representation, because the answer that's arrived will actually be quite different to different contexts. So making sure you get a comprehensive view. And then subsequently developing a framework on the back end to continue to monitoring these tools in a systematic way, and being very transparent about those outcomes and processes.
Yeah, I fully agree with everything you said. And just to add to that, at IBM, one thing that we've done internally, and now that we're kind of socializing out a process that we've developed a framework that's robust around this, is having an AI ethics board that is set up, designed to evaluate in a systematic way use cases that come to mind across the organization. And this could be decentralized on some level. At IBM, we have a combined approach, but we have a chief AI ethics officer that is kind of charged with creating a systematic approach to not only evaluate the risk that these different use cases imply, and what levers are being pulled, and how are we kind of ensuring that these use cases, once they're implemented and put into production, are transparent, are explainable, do have the right bias controls around them. And then importantly, I think part of that loop is having an audit process. At IBM, we firmly have a position that AI is there to augment the human, the employee, the customer experience, not replace necessarily. So you need, as part of that feedback loop, auditors who are subject matter experts and understand and have the right kind of level of training to go in and basically say, this is performing as expected, it's useful, it's performing within the risk guardrails that we placed, and make the decisions about whether or not to reevaluate those models that are in production.
Brittany stole my thunder a little bit, but I think it's the right point, which is this idea that there's a human in the loop, right? So whether we're talking about, just be a little techie here, whether we're talking about the data ingest, the normalization, the training, or we're talking about what you're doing with that data, runtime, how that comes into the clinical workflow, in each of those kind of three nodes, there still has to be a human who is looking at the veracity, the inequity issues, the ethical implications. And again, one of the things that can very easily become a problem when we talk about AI in any field, but especially in a regulated field like healthcare, is there's this assumption that the human just disappears. This is a tool in the toolbox, right? This is something that for you as a practicing physician, as a nurse, as a care coordinator, this should make you more effective. It should make everything that you went to school and you trained on, you should be able to practice at the absolute top of your license because of what technology is enabling you to do. And I think sometimes that gets missed. And this idea that AI, it's going to solve some problems, but every one of those solutions still on a go-forward basis requires a trained human in the loop.
Totally agree with everything that you said. So as you operationalize models, what sort of metrics should you be looking at to sort of gauge fairness or to make sure that your models are behaving the way that you're used to? I'm familiar with like model drift, right? Things that you typically look at when you build a machine learning operations platform. But what sort of new ideas, new metrics should we be thinking about when it comes to thinking about model fairness?
So one of the things that we've been doing is that some of these models actually produce sort of, when you think about the outcomes themselves, sort of numeric outcomes. But with these language models, it's words. And so you have to develop some new techniques as a result of this. So we trained this model at Google called MedPalm, which is a medically tuned model. And we got to take the USMLE, the sort of the licensing exam for medical students. What was fascinating about this is we released this model, first model, in October, and it scored about a 65%, so just barely passing, and this was the highest score. 4 months later in March, we actually got it to score 85%. To give you a sense of how rapidly the technologies are evolving, it's sort of spectacularly fast. And so, towards your point, you have to be consistent about it. One of the things, though, that the model does is that it does really good question and answer, meaning that you can submit a question, a clinical question, and it'll give you a response to sort of like, what is diabetes? Or what should I be thinking about my heart failure? And it'll give you a response. And so there wasn't a good way to sort of evaluate this for fairness because we'd never really done language models. It's a very new thing. And so what we did was we published a paper, it ended up in Nature, and we actually created a new algorithm to sort of think about what are the criteria you want to take. So one is sort of criteria that sort of consistency with sort of the expert opinion. Another was sort of understandability in terms of at the reading level, which you understand things. So really, these new tools that are being developed require new sort of techniques to sort of understand fairness, accuracy, and whatnot. And I think one of the things to think about is when we do this, creating a transparent way to understand it is critically important. Like sort of as a commentary, we frequently hear about these models producing answers that are sometimes better than what physicians say, and you've probably heard that in the media. Yeah, more empathetic and stuff. But how many of these sort of reports actually publish the criteria associated? What does that actually mean to be better than a physician? Like, what are the criteria associated? So being transparent about that, publishing that, making it known is critically important as you think about fairness.
Brittany?
Yeah, I'll just quickly add, I mean, I agree with everything you said. Transparency, explainability is really important. Being able to track bias in a quantifiable way that's meaningful to your end users and also to your organization is really important as well. And then I think you kind of touched on this, but having, again, a human in the loop who is evaluating and providing feedback on, is this actually helping augment my work and helping kind of reduce the amount of effort that I'm having to put into the intended use of this model. So I think all of those elements are really important as you're kind of considering how to evaluate a model's performance.
Just to underscore what Brittany just said, I think it's the connection, your ability to connect between drift and explainability, which is about transparency, right? So if you're building models trying to predict particular kinds of maternal care, how are you with what the model has as an output? How do you explain its findings? And if those findings change over time, which is to Brittany's point, someone has to be watching that. That to me is the connection point. That's the best practice that you have to internalize from an operations point of view.
Fantastic. Let's think about being AI ready as an industry. One of the things that I've noticed in my short time within public health is that we're missing a lot of fundamental pieces that it takes to become AI ready. And I'd love to hear your observations about what are some of those pieces that you would like to see healthcare build to get the most out of artificial intelligence. Maybe we could start with Ben.
It's a really, really important question, and I think of the answer to that question in kind of 4 buckets. The first bucket is architectural, technical, all of the things that have to do with the ability to ingest, reason over, create, initial supervised models. So that sort of like basic architectural technology set of questions is in bucket 1. I think for me, bucket 2 is regulatory, right? So we saw the 21st Century Care Act, and I think, and as competitors, I mean, we all stood on a podium at the White House and we committed to embrace interoperability standards that I think a decade ago, probably wouldn't have happened. And we're still competitors, but that second bucket is, what are regulations forcing? That's a key forcing function. So that's number 2. The third is budget. I was talking to someone who had been working with the CDC in the early days of the pandemic a bit ago here. And she made the comment about how in the early days of the pandemic at the Hill, there was this pushback around, well, why do you not have data about disadvantaged communities and the impact of the pandemic? Well, it's because they don't have budget. And so to the extent they even have data, they're faxing it in. And so there's just this third bucket, which is, okay, so you've got a regulatory mandate, you have an architecture that is data interoperable, but do you have money to actually make that happen? And then the fourth bucket for me, and I've learned this the hard way in the role that I have at Microsoft now, is do you have alignment of incentives? And not, we think a lot about that between, if you're a provider, you think about that alignment of incentives around data sharing, probably with your EMR vendor, probably with your key payer partners, but even internally, just between the different parts of your organization. Do you have incentives designed in such a way that one side of the house is motivated to tear their silo down and share data? And so to me, when I think about the answer to your question, I think you, as leaders, and especially as multidisciplinary leaders, I think you have to be looking for each of those 4 areas, and the use cases that are gonna sing in your organization are where you can find that magic thread that you can pull through each of those 4 buckets.
Yeah, I like being in the middle. I could just agree with everything everybody says. I agree with everything you said. I would just add, that's how I would think about it too. To add to the regulatory piece, as I see some of the challenges that are barriers there's a lot of barriers to implementing, including cost is one of them, but another aspect of that is a lot of the regulation around 21st Century Cares, some other regulations included, are the interpretation of the implementation of those regulations. A payer can interpret it differently than a provider, and the interoperability intent isn't necessarily there because of some subjectivity that's allowed within implementation of those regulations. So I think getting tighter on what, as we think about advocating for future regulations, future adjustments to laws, right? How do we kind of have the right level of specificity so that interoperability is from the get-go able to be specific and not open to interpretation?
Yeah, I think you're going to hear like we agree with each other a lot, which results in a boring panel. So we apologize wholeheartedly as a group. No, so it's completely agree. I think 2 things I would say. So we frequently think about infrastructure in terms of the technical infrastructure. With the generation of new tools, think about your people as well. So think about your human infrastructure. So 2 points about that. So we've heard this idea of keeping the human in the loop, critically important. And I think it was the last conversation where the woman from the Arthur Blank Foundation says that, talking about moving at the speed of trust, right? So innovation in your organization will move at the speed of trust. So take the time, build the trust, be transparent, to make sure people are comfortable with the rate of change that's occurring. Because otherwise, you will likely have some significant challenges sort of adopting new sort of technology. The other piece of this is to really think hard about sort of the skills that you need. So I mentioned I was on the AHIP panel just last week. And one of my colleagues was from Boston Children's Hospital, and they hired their first prompt engineer. And the question from the audience is, what exactly is a prompt engineer? so really, fundamentally, it is like when you think about these models, entering the input into the model, the prompt, has an effect on the answer you'll get. And so doing that well, we think, will actually improve the results that you get. So there are going to be new skills, new jobs that are going to be popping up. Invest in that workforce because it's going to matter.
Every time your 5-year-old in the back of the car keeps asking why, just channel that child into prompt engineering. That's a career growth field.
There you go. One of the things that I've noticed in public health, and as I've talked to more healthcare leaders, I don't think we're alone in public health, that we have a lot of data silos. So I'm wondering what we can learn from other industries about how to attack these data silos creatively. So maybe I'll start with Brittany, since
Sure.
you're in the middle.
So I think that as far as touching on the question about what other industries are doing, right, and how we can learn from them, had the opportunity when I first joined IBM to actually dip my toes in several different industries, including finance and retail, even though my focus was on providers, and eventually narrowed down my career to that. But what I saw was at that point in time, this was back in 2016, 2018, somewhere around there, we were observing a lot of push for a data strategy that was a single cloud or a single location or a single infrastructure, right, or architecture. And this data lake kind of strategy fell on its face, basically, after several years. And part of it is just, if you think about it, the nature of how decision-making works in large organizations. It's really hard to unify around a single data strategy that's very sustainable. And in healthcare, I would argue that is even more of a challenge, given that I think the latest stats are 30% of all data in the universe is created from the healthcare industry, and that is growing very rapidly. So a lot of it's unstructured, and that's hard to keep control around. So thinking around a hybrid approach and how you have interoperability just intra-organizationally, but also inter-organizationally is really important to think around how you're not going to necessarily move and lift and shift data, but keep it where it needs to be housed for the intended purpose, but also leverage AI or intelligent augmentation to connect to different data sources without a lot of manual effort.
So this is maybe not an answer you'd expect coming from a technology person, but I'm going to go back to something I said earlier around alignment of incentives. And I think one of the things that I see a lot of people who are technologists at their core but are not healthcare people wrestle with why these problems persist, right? And they oftentimes look to like the financial services industry and they say, well, there's another regulated industry that has figured out a lot of these problems, so why can't you? Which is a fair question. I do think, and again, this is a provocative, and I'll frame it as a question, not as an assertion, but I wonder if one of the big differences between healthcare as a regulated industry and financial services, just as one example, why do we not have the same sort of data liquidity, data gravity, is because we really haven't in healthcare, for all of the prognostication, we really haven't figured out how to make money based on that sort of data liquidity and data gravity. And make money as a proxy for saving the system money, improving outcomes. We have that as a theory of the case, and I think we're right, but I don't think we've actually validated that. In the financial services, that data interoperability, that data gravity, that data liquidity, everybody understands the business models that lights up. Everybody understands why that makes something like Mint.com a really successful financial experience from the consumer's perspective. So again, it's an unusual answer from somebody coming from a technology bent, but I think that question of alignment of incentives and what is really making the machine hum that gets you to that liquidity and that gravity.
Yeah, and my answer is sort of a variation on exactly what Ben said. You know, when I think about complex data structure and silos, you know, technically we can put the data together, like all of us can, and we all can highlight examples of it. I think that the challenge that most people sort of fail to recognize up front is the data governance, and really making sure you have a clear understanding of who owns what data, for how long, and for what use purpose. So using an example where Google worked in Oklahoma, actually on a situation that Dr. Cohen mentioned, is this idea of opiates and sort of overdoses. When you think about the data associated with that, it comes from multiple sources. Like there's the criminal justice system, there's the healthcare system, hospitals, there is the public health system, right? There is the social service system. And all these data they're not trying to keep the data away, but all these organizations have a responsibility to protect the data of their clientele. And so being clear about what the data are being used for, how it's being utilized, and how long it's being kept is critically important. You don't want to necessarily put in a data lake and keep it there, because what if it's a security leak? Then subsequently, you can leak data out from multiple institutions for all these individuals who are connected. So privacy is critically important. So defining the data governance and being very clear about the roles and responsibilities and how you're using that data on the front end is probably the most challenging thing we've come across. And then flows the technical piece in terms of breaking down the silos.
I think, Ben, you mentioned regulatory. So we have an opportunity here to ask or to use our platform here to make suggestions. So what role does regulation play in helping drive progress of adoption of AI in healthcare? How can our regulator friends help?
So I think Brittany made a point that I worry in one of my answers I glossed over, which is the regulatory front. We've made progress, but we're not there yet. Right, so I think, as technology companies, I think we need to continue to demonstrate the good faith that goes back to some of the, the announcements around FHIR 4 or 5 years ago. I think those have proven to be no regrets investments. And so I think, as technology companies, and I know Microsoft, we're continuing to invest in the Karen Alliance. We're continuing to make very strategic investments that are all organized around this idea that we want to have a voice in how these interoperability standards come together. And I think that's pretty universal across the big tech companies. We're competitors. We will compete on cost and computational efficiency and our different architectures, but we all are aligned on the fact that interoperability as a principle is something that we need to be behind. I think the work that remains to be done is at a much more granular level than it ever has been before, and I think that points to success, that points to progress. We're talking about very specific data elements. We're at a point in the interoperability conversation that 5 years ago, I think we would have all been surprised to say we could have got there, but we're there. And I think, continuing to act in good faith as an industry, standards tend to be good for industries, and I think we're all starting to come to that realization. And that's a predicate step to really unlocking the value of AI.
Yeah, I don't have a lot to add. I mean, I think that that's where my mind goes as far as we need that level of granularity in the implementation details. I mean, otherwise, we're not going to have any kind of interoperability conversation, especially as we get to the interorganizational elements of the whole conversation around population health and how AI might be enabled to help for the greater good beyond just a single organization.
Yeah, no, so again, completely agree, so apologize for the sort of the parroting effect here. But I think the only thing I would add here is that we've heard the theme team sport come up many, many times, and so the standards are so critically important. But I think the other piece is, as you think about the team sport and sort of the regulation, is really getting input from everybody, and so working in these various communities of practice to sort of inform regulation, right? So, for instance, we're involved in lots of different forums where we signed on with the agreement in front of the White House with the president. We, in addition to that, we joined the Coalition for Healthcare AI, which is an organization like with academics and researchers and government together, because we do believe building the evidence base is something that's critical at this time, and making sure that that's available to inform sort of policy in a meaningful way. Working with the National Academy of Medicine is a place where many of us also are working, so many of the same faces, because again, these forums allow us to get input and understand and learn from the larger community. Like, as we think about the future success of AI, it's not going to be because of the three organizations on this panel. It's going to be all of you who are implementing it in the real world. We're building these foundation models, which are sort of these generalized models, but you all are going to be using it, and we're going to be doing our best to help you succeed.
As a follow-up, when I was in the energy sector, I was the tremendous beneficiary of a lot of the work that some of the research labs did. In the energy sector, we have the Department of Energy, and they sponsor research labs. And I'm wondering if that's something that we're missing in healthcare. What are some of the things that we can learn from other industries and how regulatory agencies have helped drive innovation? Maybe I'll start with you, Vaughn.
Yeah, I think the idea of banding together, working with researchers, sharing information, making it very public, I think is critically important. Like in terms of federal funding, for instance, for research, that is a great opportunity for all of us to get involved and to collaborate and to build science. And then subsequently, with science, as well, whether it be computer science or the basic sciences, building upon what was sort of developed by others is critically important. For instance, the T in ChatGPT is transformers, which is a technology that was developed by Google. But some incredible things have been done with that technology, and that's wonderful. That's exactly what we want to see.
I guess the thought I have around that, around kind of the research lab and how can we kind of potentially expand, or how it might be beneficial, or if it is beneficial. As I thought about this question, I think that, going back to the height of the pandemic, right, in 2020, some of the missions of these labs that you're talking about were actually refined temporarily to actually focus on elements like discovering spikes in the coronavirus, and actually expanded to a healthcare mission, right, to leverage the quantum compute, leverage the high performance computing, all of those really advanced technologies that were traditionally used to aid the Department of Energy and research initiatives around that. I wonder if there's an opportunity to consider some of these national labs just expanding their mission to something more broad that includes some of these healthcare questions, especially as we're considering large volumes of data standards, and research around interoperability.
I think the answer to your question probably depends on making sure we get the question right. And what I mean by that is when we talk about AI, and I think, again, you don't need to be a healthcare practitioner, just in the cultural milieu, there's three things that three areas of conversation where the question you're asking is relevant, right? One is just like, how are we going to regulate this AI when it's providing medical advice? Like, okay, what is the FDA, does it have a point of view on that? If so, what is that? So there's that question. There's the question around, which I think you're asking, which is, should we be making targeted investments, in particular predicate technologies that are probably even early for the private sector to be funding, or even a nonprofit entity like OpenAI was and still is. And then there's the third question, which I think, again, your aunt in Plymouth, Indiana is probably wrestling with in her podcast, which is, what's the effect on jobs, right? And so I think it's important to, what's the question that we're trying to answer? If it's the second question, and it's around, should we have a more targeted national investment strategy around artificial intelligence, and in particular in healthcare? I think the answer is yes, but I think we need to make sure we're asking the right question first.
Thank you. We have time for one more question, and I want to follow up on something you said. You said prompt engineers, right? That's a new job title. What are some of the other new job titles that we're going to see in healthcare? I'm hiring machine learning engineers. That's a brand new role for the CDC. Same thing with data engineers. So I'm wondering, what sort of roles can healthcare expect to come as we start integrating artificial intelligence more and more? Maybe I'll start with you, Ben.
Well, I think you've seen in the last couple of months that a lot of large systems announce chief AI officers, right? And that's, you could argue that, well, shouldn't your CTO or your CIO, shouldn't they have a point of view? And I think one of the open questions is, do those roles get budget? Do they get headcount? Or are they just there as a thought leader / thought partner? But again, I think that goes back to the use case question. The more that chief AI officer can find use cases that really change the lived reality of being a physician, of being a nurse, of being a care coordinator, the more that chief AI officer at the executive level, at the C-suite level, is going to be something that's an actual role. It's going to be empowered. It's going to have budget. It's going to have teeth.
Yeah, the federal government just announced that they're asking for chief artificial analytics officers.
A new cabinet position?
I don't know about that.
Yeah,
Brittany?
I think AI ethics officers is a great, as I mentioned, IBM has an AI ethics board, including a chief AI ethics officer. I've seen those roles start to pop up. I think, as I mentioned earlier, the kind of auditory process, the auditor role that has the specific type of domain knowledge needed to provide informed knowledge. And then I just thought of a third one that I haven't necessarily seen, but I think is important. As we're thinking around how we define what a good, suitable use case is for AI. How do you have a role that evaluates and defines the right metrics, defines the right bias levers that you want to consider in that workflow, and maps the use case to the ROI or whatever metric that you're trying to evaluate so that you know how to prioritize that in that AI ethics board review process. I think that's going to be an important kind of nuanced skill set that may be an adaptation of a combination of a specialized business executive role.
So I might go with a slightly different answer for once, so, if you can believe it. No, I'm going to channel Ben and the inner 5-year-old. I think it's less about hiring specific roles and more about training your workforce. So you should all go tell your employees to tell their 5-year-old to come to work with them and ask every single question they can about the work they're doing. Because as you think about that, they are going to be the best prompt engineer that many of us will ever see, because they'll continue to ask that question about why? And it'll force you to a level of specificity that you need to actually work this. But seriously, the goal, though, I think, is there will be a handful of specialized role. I think the bigger challenge will be sort of doing this at scale across your entire workforce to prepare the workforce for generative AI, and not just generative, but AI, and using these new tools in the most effective way for health.
So you guys hear that? Channel your inner 5-year-old. If you remember nothing else, always ask why. So with that, I'd like to thank our esteemed panelists for their very, very thoughtful responses. Thank you.